Good morning, everyone. My name is Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series. It is my true honor to introduce today's speakers who will be presenting and discussing on the diagnosis and treatment of NIFTP. Our first speaker, Dr. Carrie Cunningham, is an associate professor of surgery at Harvard Medical School, section head of the Massachusetts General Hospital Endocrine Surgery Unit, and an associate director of the Massachusetts General Hospital Institute of Technology Assessment. She is the immediate past president of the Association of Academic Surgery. Her overarching research mission has been to improve health and well-being of patients with benign and malignant endocrine-related diseases and to mentor young academic surgeons. She's a leader in the field and a principal investigator of an NIH-funded research that seeks to examine the potential of impact of new diagnostic technologies and personalized management strategies in patients with thyroid cancer using mathematical disease simulation modeling, which I can honestly say is interesting and amazing work. Additionally, we are happy to introduce Dr. Ronald Ghossein, who is currently the director of head and neck pathology at Memorial Sloan Kettering Cancer Center, where his research is dedicated at enhancing the classification of thyroid carcinomas. He's published a handful of papers that have changed the way that we see thyroid pathology currently. He published his first article in 2006 demonstrating an extremely indolent outcome of the encapsulated non-invasive papillary carcinoma follicular variant, leading to the reclassification of this entity as non-invasive follicular thyroid neoplasm with papillary-like nuclear features, NIFTP. Dr. Ghossein is the senior author of the NIFTP article published in JAMA in 2016 that changed the whole world around. And he's also developed a novel definition of poorly differentiated thyroid carcinoma. He's published many articles in the stratification of encapsulated thyroid carcinoma into prognostically relevant groups, and in collaboration with endocrinology and surgery services and at MSKCC, he's helped characterize at the molecular level the follicular variant of papillary carcinoma, hurdle cell, poorly diff, and anaplastic thyroid carcinoma. Before we begin, I would like to encourage everybody to use the Q&A function to send in your questions, and we'll try to get to them before the end of the hour. And without further ado, Dr. Cunningham, the mic's all yours.
Thank you, Camilo and Mark, and everyone for joining, Dr. Ghossein. I also asked Dr. Sadow, who is the senior author, not senior to me. I think, no, you're 1 month younger than me, right? Just to join in case I screw something up on the pathology that we did. So welcome, everyone, from wherever you are around the world. I have no conflicts of interest that pertain to this presentation. So I think what I wanted to start off doing this morning is sort of give a background, a history of sort of where we've come in terms of the genotype, phenotype. When did this NIFTP? I mean, really, it's in its infancy, given that really this has only been a change in the classification in the past decade. So really, this is just a really nice figure from Nature, just showing way back. This is like, over 10 years ago, where they started characterizing. Can you see my pointer, Camilo?
Yeah, it's okay. We can see it. Yeah.
The sort of the follicular differentiation, benign at this time, follicular thyroid adenoma. Then you had your well-differentiated thyroid cancers, and then leading to poorly differentiated in ATC. And these are the classic, P53 mutation over here. And so this was the beginning of really looking at RAS mutations, and interestingly, BRAF is way back here, saying this is what would distinguish papillary thyroid carcinoma. Just getting like the sense of when we started really thinking about genotype, phenotype. Then in 2014, really around the same, we started noticing it in our own group, in a small group of these follicular variant of papillary thyroid carcinoma. And I'm hoping Dr. Ghossein will go through what all these mean for our non-pathologists. But really that we started seeing that the encapsulated versus non-encapsulated, that we were seeing a much higher rate of this BRAF. And I want to emphasize that it's BRAF's B600E mutation, because there are some 601 mutations in NIFTPs, but this is the BRAF 600E that we're all familiar with. And so this is the beginning of saying, okay, maybe there are two different forms of this encapsulated variant. And then, of course, many of us are familiar with the landmark article, first authored by Dr. Giordano, who I love to tell everyone was my pathology professor at Michigan, And so they did a really deep dive on over 500 papillary thyroid carcinomas, including 35 follicular variants, and did really every mutational analysis under the sun, copy number alterations, et cetera, and DNA methylation. And really, my simplified surgeon take-home point from this is that they really had two various subtypes, really. So there's this RAS-like mutations, which were associated with the follicular type pattern, and the BRAF V600E, which is the more papillary, the classical papillary. Please, pathologists, jump in if I'm hacking any of this. So, one thing, you know what? I'm just going to I'm going to change something here because I realize I have, never mind. I'm sorry, I have it overlaid. I have it on animation mode. So the 2016 article where we called it this paradigm shift. Many of the people on this call, Dr. Ghossein, Dr. Sadow, were on this paper. In 2016, we looked at and assigned a new nomenclature to NIFTP. So these encapsulated follicular variants with RAS-like mutations. This would, they estimated worldwide, would change the quote unquote diagnosis of over, almost 20% of patients worldwide with papillary thyroid carcinomas. And that would be either brought down to whatever you call it, borderline, low risk, and we'll talk a little bit more about that. Stole this slide from Peter. Thank you, Peter. I just want to clarify again for the non-pathologists that encapsulated follicular variant and or NIFTP does not include the follicular variants with capsular invasion or with infiltrative pattern. So in this paper, really looking at the non-invasive versus invasive, about 100 in each category, had a decent follow-up, and really none of those patients or tumors with the non-invasive pattern and the NIFTP pattern had any adverse events, including death, et cetera, clinical outcomes. Well, this just led to a whole slew of the press and patients and many people. This was all over the popular press. And as a surgeon, I can tell you this created quite a few phone calls from patients that were diagnosed with this prior to 2016. So the implications of reclassifying something, I just want to bring to the fore for this discussion. So this brought up a ton of questions for me and for most of us on this call. What does the FNA mean when there are still cellular changes when you're doing a biopsy, right? So how is this really helping us? How is molecular testing when we're trying to define NIFTP? How do we follow up these patients? And this is something we're going to poll you in a second to see what you're doing with your patients. Let's say they have a solitary NIFTP in the pathology specimen, either a thyroid lobectomy or total thyroidectomy. What do you do with that patient? Do you say, that's it, you're done, congratulations? Do you follow them every 6 months to a year? If they had a lobe, do you take out the whole thyroid? Are you doing radioactive iodine still? And then also, what do NIF micro, I don't know, I know I'm not supposed to say papillary microcarcinomas, but I don't know how to say micro NIFTP, so I apologize if that's not the way to say it. And then what's the extent of surgery? Let's say we did know, should we be doing lobes or totals if we did know that the patient had a NIFTP? And then really what's important, doesn't get discussed enough, I think, is the impact of this reclassification on research. Of course, I'm biased. I do a lot of work in this area. And when you reclassify something as a borderline or benign tumor, they are not going to be captured from 2016 on in the large national databases, for instance, SEER database, right? So it's not necessarily called cancer anymore. And people are going to be convinced that the incidence of thyroid cancer is going down in the coming years. And that's not really true. It's just that they were reclassified. We decreased the number of the denominator. And so that's going to sort of change a lot of it's going to make my life more difficult. And then additionally, there are a lot of factors that go into why someone gets a lobe or a total. And we'll talk a little bit more about that. And it's hard to say why the patient went to surgery when you're looking at it retrospectively. It may not just be because of the NIFTP, and it's really hard to parse that out from the medical record. So next, Camilla is going to try to poll those in the audience. Please be patient with us. We are trying something new today, and we'll see how it goes. So Camilla, take it away.
Thank you so much. Let's see that. Can you see the poll right now?
I think I need to stop sharing, correct?
No, I think no. I think
No?
the audience has gotten a small question that popped up in the dialogue window. So if you guys have the question we're asking, we are presented with a case of a NIFTP with no additional confounding features, and the patient only underwent the thyroid lobectomy. What would be your treatment course? So we have options for active surveillance, completion thyroidectomy and radioactive iodine, or no additional follow-up since you would define that as benign. So if you can, just give us a response, and I believe only the people in the audience can vote. Salman, can you go ahead and pull the second question, please? Just bear with us. We're just trying this now. Let's see.
Oh,
so
nice.
here we have it. Can you see the response to that? Carrie, can you?
Oh yes, I can see that. Yes, excellent. So I hope that participants can. So the majority of people stated active surveillance, and then no follow-up at all in about 30%. No one recommended completion thyroidectomy or radioactive iodine. Excellent.
Beautiful. We're gonna try to jump to the second question. So second question, if you were to follow up a patient after diagnosis of NIFTP, for how long would you recommend to follow up? First option was no follow-up needed. The second one is 6 months to a year, at least a year, or at least 5 years. So you have the option to respond to that, and we'll give you 10 or 15 seconds or so you can have a chance to respond to that, and we'll be sharing the results in just a second. Beautiful. Salman, can you help us bring the results up? Interesting.
Okay. So of those, let's see. So we have no follow-up, almost a pretty surprisingly even distribution. 6 months to a year for 19%, at least a year, and then at least 5 years. And I think that means the length. How long would you? Okay, yes, the length of follow-up. So 50% of people would continue to follow people for a prolonged period of time. So very interesting.
Awesome. And we're going to jump to the third and final question. So in cases of NIFTP, if you found to coexist with another thyroid malignancy, the treatment option you would consider is first option, individualized approach based on tumor characteristics. Second, total thyroidectomy, removal of the entire thyroid gland. Third option, total thyroidectomy and radioactive iodine. And other, and please specify in the chat if you do have another option. So we're going to give you a couple of seconds to respond to that. And let's show the results.
Okay, so the vast majority, individualized approach. Excellent. And then others said thyroidectomy and radioactive iodine. Okay. All right. Thank you so much. That worked out really well. Good job. So that actually is a perfect segue into, believe it or not, I will get to the article eventually. So we then it was interesting because when I read the article and many of us were like, we're very excited about that data, that we could at least give our patients it's nice to tell a patient that they don't have cancer. And so I was wondering though, because of this concept of, as we all know, there are multiple benign nodules, different microcarcinomas, there could be a bunch of different things going on in the thyroid, indications for surgery, right? There's a Graves' disease. And so we looked at a group of patients, some of which are probably included in the current study, but we looked at 1,300 follicular variants, 21. We just to see what the prevalence was in our group. We do quite a few thyroids every year at Mass General. And 21% of them we realized, so this is looking at the circles going as you go in. So 21% of our papillary thyroid carcinomas, this is based on a surgical pathology database, i.e. Peter Sadow, thank you. 21% of them were follicular variant. Only 4%, of those, we looked at how many had multifocal tumors, meaning did they have another cancer? Did they have an indication for the other thyroid nodule to be taken out? And really only a very small portion had a solitary encapsulated follicular variant, or what we would consider NIFTP. So it was a much smaller impact than initially thought, at least in our study. So I'm not going to go into this, but Peter did mention that there is a 2022 WHO classification for thyroid neoplasm, and just showing that NIFTP is now considered a low risk neoplasm. Again, I'm not sure how to describe that to a patient, and that's something I hope we can discuss a little bit later. Then, follow-up studies have begun looking at, obviously this paper was only, in 2016, it's 2023. So we don't have an extensive amount of follow-up, and we know that thyroid neoplasms generally have a longer course. So this is one study looking at 79 patients in 2022. Consistent with their findings, 75% had RAS mutations. The remainder, most of the remainder had this 601E. Remember, this is different. Their mean follow-up was 2.4 years, a range up to 6 years, and they did not see any evidence of recurrence. In their study, the clinicians in that group did not perform any other treatment, meaning further surgery. And initially, 75% of them had a thyroid lobectomy. Just a reminder, it's currently not possible to define an NIFTP preoperatively. So this leads to the current study that Dr. Sadow is the lead, senior author on. I believe that this QR code works. I tried it this morning. So if any of you in the audience want to pull the article down, I think you may have to have access to thyroid. I'm not sure, but the QR code does work. So I'll leave that up for a few seconds. So in the study, we looked at from 2016 to 2022, again, the surgical pathology database, we identified a total of 319 patients with a diagnosis of NIFTP. Pretty similar, pretty characteristic age, a mean of 52, majority are female. And you can look at the size of the tumors here. And I know Dr. Ghossein has a lovely article looking at NIFTPs greater than 4 centimeters, and I'm sure he'll comment on that. And then interestingly, I don't know, in my clinical estimation, I thought that NIFTPs, similar to follicular adenomas, would be sort of a solitary tumor, and which is true for the vast majority. 88% of those with a NIFTP diagnosis had only one NIFTP within the gland or whatever was excised. But there were others, up to 12% that had multiple NIFTPs within the gland. I just had to put the slide in here because it's beautiful. And I'm sure Peter took these pictures. So the A and B panels on the top, this is showing a NIFTP, I believe, showing that there's no vascular invasion. Here showing a follicular type growth pattern. Oh, this is fun. I love describing slides in front of two pathologists. Showing nuclear features, some occlusions, I think some nuclear folding.
Just so you know, this is horrifying.
And this is an
The
HBM
first one is
slide.
showing not vascular invasion, showing no invasion of the tumor.
No invasion. Okay. And this is an HBME stain here. And then C and D are looking at the typical classical papillary thyroid carcinoma showing invasion. This is a BRAF 600E stain here. And this is showing the papillary-like structures. All right, I'm moving on. So again, this is looking at 319 of a total of 4,800 thyroid surgeries over the course of 6 years. So about 6%. And again, this thyroid surgeries aren't all cancers. They're for other reasons, multinodular goiter, Graves' disease, et cetera. So it's 6% of our what was in our database. This is a really full slide, so I'll walk you through each one of them. We broke down the group of the 319. We broke them down into 3 different categories. One being NIFTP only, and they could have multiple NIFTPs, but only NIFTP as a diagnosis within the gland that was removed. And there was 183 of these. The second group was a patient with NIFTP, but had only one papillary thyroid microcarcinoma, which, as we know, are found on autopsy up to 30% of people. And the third group is basically everything else, anything more aggressive, classical papillary, moving on up. And so here we see on the upper left, this is showing of the NIFTPs that had FNAs, which the vast majority did. That's how this is looking at over the course of time. So 2016, 17, all the way up to 2022. This is looking at the Bethesda classification of the FNA of the NIFTP. So over time, you can see, so Bethesda 3 is really the most common. So AUS plus, I know they've changed the criteria a little bit, the naming of the criteria. We see the green here. This is the Bethesda 4, which is the suspicious for follicular neoplasm. But interesting thing, and the important thing here is that we do see the purple and the gray here, which are non-diagnostic and benign. So if someone only had a biopsy of the NIFTP and it was benign, there are still up about 20%, 18% of people that really don't have an indication for surgery, but somehow we have these, we are still taking these out. Again, this is a little confounded, just makes studying it difficult. So this is now moving on to patients who had molecular testing and showing that that patients did have some suspicious molecular characteristics shown in red here. These are the molecular alterations that are seen. Again, the RAS mutations, NRAS, KRAS, HRAS, and this theta or theta, as these are commonly associated with the NIFTPs. And this is just showing a really nice, and I'll actually show this in the next slide because I think it's really important. Sorry, 2 more slides. Then we looked at, again, this is retrospective, so this is not predictive. This is in our group of surgeons and endocrinologists. We have 6 endocrine surgeons and a number of multiple people in the thyroid unit, the endocrinologists. Of those that wound up getting total thyroidectomy, it won't be surprising that on multivariable analysis, the things that were correlated with the decision to go to total thyroidectomy were a higher malignancy risk to start out. And then interestingly, whether or not the patient was already on thyroid hormone, not surprisingly, that's up here on the top. So not surprisingly, if they had more worrisome characteristics, they got a total thyroidectomy. And this is something that I think is really important to look at. So looking at a multitude of studies that have looked at NIFTP, some of which were retrospective and just making the generalization that encapsulated follicular variants were NIFTPs, which was just difficult based on the fact that we didn't have the criterion when these things were diagnosed. And it's difficult to go back and look at all of the slides, but this is just showing in general that a lot of people are still doing total thyroidectomies in these cases. Of course, you don't know this, you don't know it's a NIFTP preoperatively. So this is, take that with a grain of salt. And then so our group sort of put this out here, this management algorithm that NIFTP only could be routine follow-up and or active surveillance. and really treating the NIFTP and papillary thyroid microcarcinoma just solitary or could also go into that group. And then obviously group 3 would be treated traditionally. So that's all I have for now. I'm hoping we can open this up for discussion, and I'm happy to answer any questions in the chat.
Thank you, Carrie. If anyone has any questions, please do type them in the Q&A function, and we'll, for the moment, go to Dr. Ghossein's presentation, and we'll come back for discussion at the end.
Okay, well, thank you for inviting me. Thank you, Dr. Cunningham, for this very nice lecture. So I have no disclosures. So what I'm going to do in the next 20 minutes is I'm going to, of course, discuss the paper, but we'll discuss it en passant because Dr. Cunningham did a very good job. I will discuss it within the context of the NIFTP story. So we'll talk about how we got into the NIFTP concept. We'll talk about the diagnostic criteria for NIFTP, the histology criteria for NIFTP, and then I will update you on what we decided in the 5th edition in regard to NIFTP. So the story starts in the 1950s. At that time, it was very easy to be a pathologist because if the tumor grew in papillae, then it's papillary carcinoma. If the tumor grew in follicles, you just call it follicular carcinoma. Follicles, I mean by that, for those who are not pathologists, small glands. But there was a paradigm shift in the 1960s where a pathologist from California, Stuart Lindsay, noticed that the tumor that were papillary carcinoma had distinctive nuclei. There were enlarged, clear, irregular nuclei, the one you see in papillary carcinoma now. And he noticed that some of these follicular tumors, follicular carcinoma, had these nuclei. And so he coined the term follicular variant of papillary carcinoma. But it is Dr. Juan Rosay, that many of you know because of his contribution to thyroid pathology, who put this entity on the map in 1977 when he described 7 cases of follicular variant of papillary carcinoma that had, most of them, 5 out of 6, had lymph node metastases, so they're really cancers. And there was a little detail that nobody paid attention to, is the fact that none of these tumors were completely encapsulated. So they were basically invasive tumor. And after that article, there was an explosion in the diagnosis of follicular variant of papillary carcinoma. So pathologists started to call any tumor that had follicles, papillary carcinoma nuclei, and carcinoma, even if it was encapsulated and without any invasion. And there was really no meticulous study of its outcome for decades. But in the early 2000s, we started to realize that we start to learn about the molecular pathology of thyroid carcinoma. We start to realize that the follicular variant has a different molecular profile from classical papillary carcinoma, similar to follicular adenoma and carcinoma. And one of the first papers that found that was from Yuri Nikiforov from University of Pittsburgh, who like 20 years ago showed that if you, in the follicular variant as a group, you have 40% RAS mutations. It's kind of similar to follicular adenoma and carcinoma, very different from classical papillary carcinoma. You notice also that he found very few BRAF V600E mutations, so in a sense far away from what you expect in classical papillary carcinoma. We actually at Memorial at the same period, almost 20 years ago, were interested in that issue, and we published this paper using comparative genomic hybridization, the old style, with a surgeon. So basically the greens are the gains of chromosome, the losses are in red, and you don't need to be a cytogeneticist to realize that the follicular variant is very different from classical papillary carcinoma. So there were also other articles, actually a very good article that Dr. Cunningham mentioned from Tom Giordano, not the TCG article, but other articles. So the question then came is, does the follicular vent of papillary carcinoma belong to the papillary carcinoma family of tumor because of such a different molecular profile? And we thought at Memorial the best way to answer this question is to study the behavior, because at the end, that's the really the ultimate determinant of how the tumor should be classified, at least in my opinion. So we undertook this study in 2006, so now a long time ago, with Dr. Giovanni Tallini from the University of Bologna and the Memorial group. And very briefly, we looked at follicular vent of papillary carcinoma, follicular adenoma, follicular carcinoma. In this paper, we excluded sub-centimeter carcinoma because we thought that they have, they are very indolent tumor. And we did a little bit like what Peter Sado did in his paper. At least in group 2 of the paper, we just added a few only a few foci of papillary carcinoma, maximum 2. And what we got is 2 animals, so to speak, this encapsulated follicular vent that Dr. Cunningham told us about with this capsule. And here you see the lack of invasion, the follicles, and the nuclear features in the inset. But there was, as I mentioned, another type of animal, so to speak, which this infiltrative follicular vent, which have fibrosis, and very importantly, they infiltrate the thyroid in a little bit kind of spider-like fashion. You see here this neoplastic follicles indicated by the arrows, percolating in between non-neoplastic ones. All right, so what does it mean for a clinician? Well, this is where it becomes really interesting, because you can see that the infiltrative follicular vent have, at least in this old specimen, a lot of lymph node metastases. That's what you find if you take if you do lymph node dissection on every papillary carcinoma, probably. And 65, like classical papillary, while when you get into the encapsulated follicular vent, even if there is invasion, there is a very small chance of lymph node metastasis. There's a small chance, like around 17%. And those who have no invasion, and we found absolutely no lymph node metastasis. But perhaps the most exciting finding with this one is that there were cases at Memorial in the 1980s and 90s, which were not treated only by lobectomy with no RAI. And there were 31 cases of encapsulated follicular vent without invasion, what we would call now NIFTP, that were treated just by lobectomy, as I said, with a median follow-up of 11 years and a median size of 2.3 centimeter, and nothing happened to them, no recurrence, no lymph node metastasis. And after this article appeared, other article in the literature reproduced kind of these findings. Now, there was a case in the Brigham that recurred, but it was at the margin, so we'll never know if it is really invasive or not. The whole capsule was not examined. There's a case that Dr. Livolsi published actually a long time ago, before even our paper, of a non-invasive encapsulated follicle that traveled to the bone. But after discussion with Dr. Livolsi, as you know, it's a very prominent pathologist at University of Pennsylvania, she told me that the whole capsule was not examined because in the past we were not very careful in examining thyroid tumor. So it looks like there is a very low recurrence rate in these tumors. Now, if you look at the genotype, and we did it in this article in the long time ago, 2010, of this subtype of follicular vent, you clearly see that the encapsulated follicular variant has no BRAF mutation and 36% RAS mutation, a little bit like what you find in follicular adenoma. And while the infiltrative one have some RAS mutations, but not as much, and they have definitely BRAF mutations. So clearly here, you know, the concept of follicular vent being a part of papillary carcinoma as a whole is not valid anymore. So you have basically 2 types of follicular vent: this infiltrative, which is close to classical papillary carcinoma, and the encapsulated follicular vent, which is close to follicular adenoma and carcinoma, not only by its molecular profile, but also by its behavior, because you know, when there is no invasion, nothing happens to this patient. And when there is invasion, I didn't mention the interest of time, when there is actually a lot of vascular invasion, you have a chance of distant met, but here in this case, the distant met will bypass the lymph node, really behaving like a follicular carcinoma. And in that paper in 2006, me and Professor Tallini, we thought, oh, maybe this should be classified as a close entity to follicular adenoma and carcinoma, you know, to spare unnecessary treatment. It didn't work at that time. Pathologists were not convinced. Then we said, well, maybe if we tell our friends, clinicians, well, don't do anything. You know, we're calling this cancer, but really it's not like a cancer. Well, that approach, unfortunately, to be a hawk in the diagnosis and a dove in the treatment failed miserably. Partly it was due to endocrinologists. Sorry if somebody's an endocrinologist in the audience, who think radioactive iodine is water. You know, some people don't take it that seriously, but it's not water. It has side effects. We all know about it, like salivary gland damage or lacrimal gland damage, even in small doses. There were surgeons, even on this island, who were very aggressive in the treatment of papillary carcinoma. Even with sub-centimeter papillary carcinoma, it's very difficult to convince them. And then, of course, the people to blame are expert pathologists like myself. I wouldn't say Dr. Sado, at that time he was young, who failed to communicate the extremely indolent nature of this non-invasive encapsulated follicular variant. And finally, after 30 long years of overcalling and overtreating, people came to their mind. And this is the paper that Dr. Cunningham mentioned, where there was a reclassification of the encapsulated follicular variant non-invasive as NIFTP. So a few details here, because to tell you that this was a serious paper, because we were 24 endocrine pathologists, including, of course, Dr. Sado, that is on the call here. And we were from all over the world. There was a surgeon from MGH, actually 2 endocrinologists, even a psychiatrist from MGH, whose specialty, research specialty is the impact of nomenclature on patient psyche. So in that paper, there were, you know, this papillary carcinoma coming, follicular variant from all over the world, and we agreed on 109 as being non-invasive, and it's difficult for 24 endocrine pathologists to agree on them. Only one person knew the outcome, and all of them had at least 10 years follow-up, and so a median of 13 years, so very serious stuff, and no recurrence. And again, if I repeat myself, no radioactive iodine. Now, so the paper that by Dr. Sado and his colleagues really confirm these findings. Unfortunately, as mentioned in the paper, the follow-up was short because they focused on the cases that were diagnosed after this article appeared. So this term, by the way, non-invasive follicular thyroid neoplasm with papillary-like nuclear feature, don't blame it on me. It was the creation of Dr. Peter Sado, but I think it's a long term, but a very good term, because it extracts the word carcinoma from it, because we were told that it's very difficult for you clinicians to de-escalate treatment when you have a carcinoma in the diagnosis. So how do we diagnose NIFTP? First of all, the tumor has to be encapsulated or well demarcated. Fine. It has to lack invasion, which is also very important. It has to lack nuclear features, you know, necrosis, or even a little bit of even a moderate amount of mitotic activity, like 3 mitosis per 2 square millimeters. Of course, it has to have the nuclear feature of papillary carcinoma. Usually they are mild. And one point of contention really was the amount of papillae you allow there. So we pathologists knew by experience that the more papillae you allow in a tumor, even if it's encapsulated, the higher chance of lymph node metastasis. So we arrived to this compromise of a few papillae, less than 1%. After this article appeared, however, 3 studies showed nodal metastasis in NIFTP. And now I have to tell you that 2 of the papers did not exclude cases with separate papillary carcinoma. So there were like group 2 or group 3 of the MGH paper. And in this, if you do that, you cannot be sure that the metastasis doesn't come from simply the papillary carcinoma. Now, there was one paper where you really can assess a natural history of NIFTP. This is a paper where the whole thyroid was examined and there was no carcinoma. In the few that had metastasis, there was really no molecular assessment of the metastasis, because we have published a paper at Memorial where we showed that you can have lymph node metastasis, I'm sure Peter saw, in cases where the whole thyroid lacks a papillary carcinoma. Maybe it was embedded in the tissue block, or it has basically burnt out, it has regressed. And I was very happy, and this is where what I liked in the MGH paper is that you had 2 cases with NIFTP with lymph node metastasis. Now, in these 2 cases, the lymph node metastasis, if understood, were stained with BRAF V600E. They were positive. So there is extremely low chance that this comes from the NIFTP. I know that the whole thyroid was not examined because the patient did not get a completion thyroidectomy, at least within the Harvard system. So we will never know if this patient has papillary carcinoma. But the only fact that these 2 cases had BRAF V600E, in my opinion, confirm that these do not come from the NIFTP. So now these 3 papers created a lot of havoc, and we basically, some of the colleagues in the group a little bit panicked and said, okay, let's just not allow any papillae in our definition of NIFTP. And here is where I respectfully disagree with the MGH paper. I think it would have been good to include these cases, although it would have been complicated because they had to relook at all their papillary carcinoma. But that would have been interesting to see what happens to those. So I personally was not, as you can see, was not very keen on this change in criteria. So again, I published this paper with my friend Giovanni Tallini from the University of Bologna, and where we basically looked at 235 encapsulated papillary carcinoma. We assessed the amount of papillae. This was led by Dr. Bin Shu, one of our very successful pathologists here. And you can see in the encapsulated non-invasive papillary carcinoma that you have to arrive to almost 10% of papillae to start to have lymph node metastasis. So I thought the 1% cutoff is reassuring. And as you can see, the more papillae you have, the more BRAF V600E mutation you have, and the less papillae, the more RAS mutation. Now, we found a RAS mutation rate of 39%. In the MGH paper is 82%. Qualitatively is the same. You know, they both prove that it's a RAS-driven tumor. Now, maybe the truth is in between, because we used an immunostain, which is not always very sensitive, to pick up this RAS mutation. We looked only at the codon 61, while in the MGH paper, this was based on genotyping. So probably the truth is in between. But anyway, qualitatively, the same findings. Now, you know, in the WHO, there was a little fight regarding the papillae, the cutoff for papillae. Luckily, Dr. Tallini has published a kind of chapter in a book, I think, where he reviewed all the cases of NIFTP until 2021 that were published. So around 1,000 cases. And what you notice here, that if you believe that these cases have nodal metastasis, when they use the 0% criterion or the 1% criterion, basically the lymph node metastatic rate, if we believe they are, is the same. Actually, in the 1%, you have even half of the nodal metastatic than the 0%. So I was able to convince my colleagues and the WHO that since you pay the same price for going from 0 to 1% cutoff, why subjecting this patient to completion thyroidectomy and all the other problems? So this is the update to the WHO. We kept the original criteria, and And the other change, and we introduced a new criterion that you cannot really call an entity NIFTP if it has BRAF V600E mutation by immunostaining or molecular. Now, I have to tell you, I saw one NIFTP with this one BRAF V600E, nothing happened to it. Biology is not perfect, but a person in WHO, I was ready to sacrifice like one patient out of thousands to spare the few patients that were called NIFTP, but actually were not NIFTP, had some tau cells, and we found out later these tau cells because they were BRAF V600E positive. All right, so now Dr. Cunningham mentioned the issue of sub-centimeter NIFTP. When the NIFTP paper appeared, as you can see, many of the paper, including the original one that we did, we excluded the sub-centimeter NIFTP because we knew they did very well. But here, so some of my pathology colleague questions, you know, the sub-centimeter NIFTP concept doesn't exist. But with Peter and other centers, we joined hands and we published a paper in 2018 with Peter Sado showing that nothing happened to, as logically what would think, to this sub-centimeter NIFTP. Another group confirmed these findings. Now, the British pathologists panicked. I don't know why, because they said, oh, if there are oncocytes, I don't trust this, you know, this must be cancer. So we proved it also that nothing happens to this patient. And my endocrinology colleagues at Memorial were very nervous about the tumor more than 4 centimeters, and I understand them. But we here also published a paper that showed that these cases do not recur, as long as they are very well samples, obviously. So another issue that was mentioned by Dr. Cunningham briefly is the issue of the incidence of NIFTP. Originally, we thought it was in around the 15 to 20% of papillary carcinoma. It was based on a few Italian and American studies and institution. Now, Dr. Bishkov, who works in Japan now, did kind of a meta-analysis, found out that 9% of all papillary carcinoma worldwide are NIFTP, and there was many more NIFTPs in the Western series, basically in North America, than in the Asian series, because we are much more aggressive in calling tumor cancer, maybe because of medical legal issue. Now, it was really interesting in the MGH paper that you guys are up to 6.6%, but this is of total thyroidectomy. I would have loved to know the percentage out of all papillary carcinoma. Maybe it's the half. We will see if Peter or Dr. Cunningham can answer this question. Now, very briefly, we are at the end. So whatever the number of cases, there is no question that, you know, if you spare the patient a diagnosis of carcinoma, you can save them from completion thyroidectomy. We all know the complication of this, especially the surgeon, from recurrent nerve injury, hypoparathyroidism. Of course, you may escape thyroid hormone replacement. We talked about side effects of radioactive iodine. Regarding healthcare costs, actually, Dr. Mark Erkin's group published a paper when NIFTP appeared 2016, really showing that you can save a lot of money if you change the surveillance of NIFTP without accounting even for the thyroidectomy. Mike Tuttle and Gregory Randall from MGH, Mike Tuttle from MCC published a paper more recently, and they came with these numbers. I don't understand anything how this is done, but just want to tell you $40 million per year, 340 quality adjusted life years, I guess good quality of life. And also, of course, the psychological and financial burden of cancer diagnosis. I think in the Erkin's paper, it's mentioned, based, I think, on another study, that 43% of papillary carcinoma patients are highly stressed using some psychologic tools, despite the fact of having a very indolent tumor. So briefly, to conclude, I think we learned we learned some lessons from this misclassification. Well, first we learned that you have to take into account not only the histology, but of course the genetic when you use a classification, because we were tipped off by the genetic data. And also the basic was not done. All the surgeon and the pathologists throughout these years that publish on papillary carcinoma follicular vent, they basically, sorry for the term, screwed up. They just lumped the infiltrative and the follicular vent together, and we didn't have an idea of the outcome. And finally, we understood that the use of the term carcinoma has enormous impact, not only, of course, on the patient, but also on the clinician. And finally, this is my last slide, so we can have some discussion. I would like to finish with this statement from Julian Huxley, who was a British biologist, and he was giving a talk at the Sloan Kettering Institute a few hundred meters from my office where I am now in 1958, before I was born, definitely before Dr. Cunningham and Sado were born. And he said that cancer must be defined operatively in terms of what the tumor cells do, not what they look like. Otherwise, the term ceases to have biologic meaning. If we had followed this dictum, we would not have probably overtreated so many patients. I think enough NIFTP for today. Thank you.
Well, thank you very much for your presentations. I would first like to thank Dr. Carrie Cunningham for an incredible presentation on your paper. I would also like to thank Dr. Sado and his team for incredible research that they put together that was the spark of this presentation. And finally, thank Dr. Ghossein for this, as you elegantly put it, en passant presentation of NIFTP. I think I understand more about pathology in the past half hour than I did in years of reading about this thing. So thank you for that. I would first, I don't want to miss the opportunity to have Dr. Sado, give the opportunity to Dr. Sado to give us any comment or insight on NIFTP or anything that you might have found interesting in the presentation.
I don't have much to say. I told Ronnie I was going to keep my mouth shut. I think he covered it extremely well, and even his comments about, you know, looking back at the papillary thyroid carcinomas, the follicular variants, we actually didn't do that in this study. And then the other question he'd asked actually about the percentage of papillary carcinomas that were from NIFTP, which we actually also did not calculate. It's easy to do that, and we can do it, but we didn't do it. So
I just want to comment that we did do a paper that you're on in 2017 that I talked about.
Yeah.
So we went back and looked, you actually looked at this, and about 20% of people with just the papillary thyroid carcinoma on the diagnosis, 20% have had follicular variant, and the vast majority of those were encapsulated. But then we went and looked at the indication for surgery, trying to figure out, of course, this is retrospectively.
Yeah, that's the old ones. Really, that's about in this paper. We didn't do that for this.
No, one. I know. No, I know. Yeah. Really only changed that what we would have classified it in about 6% of patients also. So it was a really low number. Again, we can't define this preoperatively because we don't have that diagnosis. So would either of you comment on the status of, maybe you know about current research, whether or not the molecular testing is getting better at figuring out a NIFTP preoperatively?
Peter, you want to take it, or you want to take this one?
You're the pathologist.
Yeah, unfortunately, no, you cannot, using the molecular assay, differentiate between a malignant encapsulated follicular event with invasion, even with a vascular invasion, and a NIFTP, because often they are both RAS mutated tumors. And yeah, we unfortunately cannot do that. Some people believe that you can find the RAS mutation even in what I call hyperplastic nodule. So yeah, I don't think there is. But just Dr. Cunningham, I just want to know, so at the end, in the 2017 paper, what was the percentage of NIFTP or non-invasive follicular event? 6%, you said? Or
so let's see. So I'm looking at the thing. So we had 13. So this is over 2006 to 2016. So a 10-year period of time, 1,300 patients that had follicular variant of papillary thyroid carcinoma on the path slide. 21% of those, I got that wrong, 21% of the follicular variants were definitively encapsulated, or as mentioned, they were encapsulated. So that's a fifth of that. So a very low percentage. So of those, 4% of them, so really about, sorry, I'm just doing math in my head quickly. So about a quarter of the encapsulated follicular variants would have, if we knew it was an NIFTP, we had a magic wand, we wouldn't have done surgery, right? So it really only changed what we would have done surgically in a quarter of those patients.
Yeah, probably 5% then, yeah.
Yeah.
So just one more comment in terms of the cytology, because so as Ronnie mentioned, it's kind of RAS mutated. We can't tell the difference between RAS mutated, but that's the same thing as his, Ronnie's paper from 2006, which was prescient in terms of calling them follicular adenomas, which should have stuck at that time, because RAS mutated lesions, whether or not there's nuclear atypia or not, the differential diagnosis is adenoma versus sort of minimally invasive carcinoma. If it's a widely invasive carcinoma, it's going to be obvious from imaging. And so in terms of cytologically, if it's BRAF V600E mutated, which you'd get from the molecular testing, it excludes it. It's papillary carcinoma. If it's RAS mutated, then and has nuclear features, then the differential is going to be invasive follicular variant versus adenoma, essentially at that point, or NIFTP. So we can do it. It's just not, the idea is at that point minimal invasion that we can't rule out. Molecularly, we know it's going to be adenoma / NIFTP, but at that point you just can't rule out minimal invasion, which would still require a lobectomy.
So Ronnie, if I could just ask a quick question. Ronnie and Peter, you guys see a ton of consults coming in from outside hospitals. This is really targeted towards clinicians who are not practicing at an academic medical center. How often do you change an outside diagnosis of NIFTP? And what questions should a clinician not practicing at an academic center be asking their pathologist to confirm that, yeah, that's the right diagnosis here?
Ronnie, you can do it.
So, okay, to quickly, because we don't have much time. Yeah, I personally will see with Peter, I change diagnosis because, pathologists in private practice are not focused like Peter Sado. They don't look at head and neck all day long, so nothing to blame. They have to deal with a brain tumor and stuff like that. So the assessment of nuclear feature, which is subjective, but more seriously, two other things that sometimes there's a discrepancy in regard to what constitute capsular and vascular invasion. Now, the most important thing I think a clinician should do is two things. Be sure that the whole capsule is submitted. And the second, be sure that at least one pathologist in the group focuses on thyroid. He or she can go, let's say, 3 weeks to MGH to look at the way they diagnose tumor and so forth. It doesn't need to, you don't need to do a fellowship in that. And that if, for example, in a small private practice, there's an important thyroid surgeon who's coming. And actually it happens sometime with me. I have people come and do that, yeah.
Can I make a comment about that? Because I think just overall, the importance of the relationship with your pathologist is critical. I've learned so much, and endocrinologists and medical oncologists, but I have learned so much from Peter, and I think you learn a lot about biology, a lot about behavior by really having a good relationship. I always go to the look at my own. I go to the pathology labs, the frozen section lab. You really can learn an incredible amount, as you can see from this talk.
Terrific.
Yeah, I have to echo that. I think this summer in the World Congress of Thyroid Cancer, we spoke about disparities in treatment worldwide, and being in a Latin American country, I can say that the experience with NIFTP is a little bit different, and the level of trust you have with your pathologist defines what you do thereafter. So I think that's really interesting, and we'll take Dr. Ghossein's word for sending someone to your institution to train under you. Going back to Dr. Erkin's and Ilya Liktorov's paper, and they said 43% of people are a little bit worried about the diagnosis of thyroid cancer. And just based by the poll that we've done earlier, it seems like we are too. It seems like people are following this for 6 or more years, and should we be doing that? And I'm going to open that question up to the panel.
I'm going to take that because, that's what a lot of my research in. So one of my studies I'm looking at, and we need to be careful. I know Dr. Ghossein talked about quality adjusted life years. This is a whole nother conversation to have, but the way you measure quality adjusted life years. So this is what we use as sort of the adjusted life year of a patient with thyroid cancer. So do they have a decrement from 0 to 1? So 1 being perfect health, 0 being death or near death. And the thyroid cancer patients usually are way up there on standardized scales, on generic scales. We do not have a good instrument. I'm just going to summarize this in 2 sentences. We do not have a good instrument, meaning that the survey to ask people about quality adjusted life years, which is critical in thyroid cancer patients because they have a long survival period. Our group is in the process of developing a thyroid cancer specific index that we can assess quality adjusted life years. So patients, I can tell you from the surveys I've done in the past, the best thing we can do for patients is not to diagnose them with anything. But that's a totally different conversation to have, because once you tell a patient that they have a borderline tumor, they have a cancer, they have all these other things, it sets them down a path that causes them a lot of anxiety. And please don't ever tell your patients they have the good cancer, because they really don't like hearing that. And so I think, this is a theoretical question, ethical question, and all those other things. And I think all of the associations have done a really nice job of really increasing the threshold for taking the risk on our part, increasing the threshold for when we biopsy patients, observing patients with low malignant risk and things like that. So that's my little soapbox for a minute.
I think that's a great insight and great ways to close our session today. We're hitting the 9 o'clock hour here. Before we leave, I will definitely like to thank you all for taking the time to be here. And I would like to invite the rest of the audience to join us next week, as we will have a presentation by Dr. Ghossein on dabrafenib versus dabrafenib plus trametinib in BRAF mutated radioactive iodine refractory disease. So we'll hope you all can tune in and have a great and safe weekend.